Hello everyone. Welcome all of you to this session of Cuddles online neonatology lectures. And welcome. We are going to discuss about one of the common problems for which we as pediatricians and neonatologists get consults for antenatal counseling. For which we as pediatricians and neonatologists get consults for antenatal. So antenatal hydronephrosis or renal pelvic calcium dilatation is reported in almost 1 to 5% of all pregnancies. Or renal. The systematic approach to the management, screening, detection of antenatal hydronephrosis, postnatal imaging, and final diagnosis counseling is very important for us as pediatricians to manage these patients optimally. So to do this, we have two speakers today. We have Dr. Goutami, who is consultant neonatologist at KIMS Cuddles Neonatology Unit. And she is going to discuss about the antenatal aspects of hydronephrosis, how to counsel such patients, how do we follow up these patients in terms of postnatal imaging, postnatal ultrasound, how we do grading of severity, and in which cases further imaging and further evaluation is required, and the steps of medical management, including uroprophylaxis. To discuss the surgical aspects, we have Dr. Yoga Nagendhar, who is our Chief Pediatric Surgeon and Pediatric Urologist, who shall be detailing about the surgical aspects of management of antenatally diagnosed hydronephrosis. Although only a small proportion of antenatally directed hydronephrosis end up in end-stage renal failure because of conditions like PUV, posterior urethral valve, overall, it is very important that we understand the principles of postnatal diagnosis, imaging, ultrasound-based severity grading, and the role of uroprophylaxis and further imaging like renal dynamic scan, so that we do not miss even a single case of obstructive uropathy. With this introduction, I'll hand over to Dr. Goutami. So that we do not miss even a single case of obstructive uropathy. With this introduction, I'll hand over to Dr. Goutami. Hello, good afternoon, everybody. I'm Dr. Goutami, one of the consultant neonatologists at KIMS Cuddles, Kondapur. Today, I have been discussing about the few aspects of antenatal hydronephrosis, how to approach antenatally and postnatally. Discussing about the few aspects of antenatal hydronephrosis, how to approach antenatally and So, on the following headings, we'll discuss the antenatal hydronephrosis today. Definition, embryology, differential diagnosis of antenatally diagnosed hydronephrosis, classification, how to approach, prognostic indicators, and medical management. So, what is antenatal hydronephrosis? Antenatal hydronephrosis, hydronephrosis is nothing but dilatation of the renal pelvis. So, renal pelvis anteroposterior diameter more than 4 mm in the second trimester or more than 7 mm in the third trimester is labeled as antenatal hydronephrosis. So, there are increased number of hydronephrosis in the nowadays due to widespread antenatal screening. CACUT is nothing but congenital anomalies of kidneys and urinary tract. The prevalence of antenatal hydronephrosis ranges from 0.6 to 5.4%, and most of the hydronephrosis are transient, that is, they resolve by the end of the third trimester, mostly in half of the cases, and they resolve by birth or during infancy in 41 to 88% of the cases. So first, we will discuss about the pathophysiology. So further understanding the pathophysiology, we need to know about the development of the renal system in regard to the antenatal hydronephrosis. So first, during the 5th week of life, the urethral bud arises and it penetrates into the mesenchyme. This mesenchyme is known as metanephric blastema, which forms the renal parenchyma. And this urethral bud undergoes nearly 15 generations branching to form the collecting system, whole of the collecting system. So initially the urethral bud develops as a solid canal of fibrous and which recanalizes later. And around the 10th week of life, distal to the ureter, bladder develops, and around 12th week of life, the urethra will develop. So, I'll just brief the development. Neonatal birth arises from the Ulpian duct during the 5th week of gestational age, and it penetrates the mesenchyme known as metanephric blastema, which forms the renal parenchyma. And most of the nephrons develops by the end of the second trimester. And this uretral bud undergoes 15 generation divisions to form the whole collecting system. So embryologically, it develops a solid cord and then recanalizes. So, and bladder develops around 10 weeks and urethra around 12 weeks of gestation age. So, any obstruction in the recanalization process will lead to antenatal hydronephrosis in the proximal to the obstruction. Obstruction in the recanalization process will lead to antenatal hydronephrosis in the proximal to the obstruction. So, in the fetal life, placenta acts as a fetal hemodialyzer, and fetal kidney starts producing the urine, and it will be mostly hypotonic from 5 to 9 weeks of gestation. And deficiency at any point along the urinary tract leads to the proximal dilatation of the collecting system. It can be transient or persistent. If the obstruction is persistent, it affects the development of the nephrogenic tissue anatomically and functionally also, leading to cystic dysplasia, complete or partial renal agenesis, and renal impairment. So some of the terminology is useful while going through these classes are isolated hydronephrosis. What is isolated hydronephrosis? It is renal pelvic diameter is increased, but there is no ureteric or bladder abnormalities. It has good prognosis. And bilateral hydronephrosis, it involves nothing but involving the both kidneys or hydronephrosis in the solitary kidney, also known as congenital solitary kidney CSK. Another important term is suspected lower urinary tract obstruction. How will we suspect lower urinary tract obstruction depending upon the scans, antenatal scans? If there is bilateral hydronephrosis and associated with thick-walled bladder that fails to empty and dilated posterior urethra, along with that oligohydramnias, all these features will should have a suspicion that the developing fetus is going to have lower urinary tract obstruction. Have a suspicion that the developing fetus is going to have lower urinary tract obstruction. So what are the differential diagnoses in a case of antenatally diagnosed hydronephrosis? Most of the cases, as I told, are transient, which resolves by the end of the trimester or by infancy. Those are 41 to 88%. Another important cause is pelvic ureteric junction obstruction, which accounts for 10 to 30%. Vesicoureteric reflex, which accounts for 10 to 20%, and vesicoureteral junction obstruction due to megaureter and other causes, 5 to 10%. Multicystic dysplastic kidney, 4 to 6%. Duplex kidneys, ureterocele, 2 to 7%. Posturethral valves, 1 to 2%. And other uncommon causes are urethral atresia, urogenital sinus, prune belly syndromes, and other tumors. And other uncommon causes are urethral atresia, urogenital sinus, prune belly syndromes, and other. So, let's see the classification: mild, moderate, and severe, depending upon the measurement of the renal pelvis diameter. So, in the second trimester and in the third trimester. In the second trimester, if the renal pelvis anteroposterior diameter is 4 to 6 mm, it is labeled as mild, 7 to 10 mm moderate, and more than 10 mm as severe. Whereas in third trimester, mild 7 to 9 mm, moderate 10 to 15, and severe more than 15 mm. Whereas in third trimester, mild 7 to 9 mm, moderate 10 to 15, and severe more than 15 mm. So, antenatal monitoring. We have diagnosed in the normal antenatal scans that fetus is having increased anteroposterior diameter. So, next, how to follow up that mother? So, if it is unilateral, if we do at least one scan in the third trimester so to see any increasing or decreasing in the diameter of the renal pelvis. If it is bilateral, then we will follow up with serial ultrasounds 4 to 6 weekly. And if any suspicion of lower urinary tract obstruction, we will follow frequently, like 2 to 3 weekly also. And if any significant extrarenal anomalies are there, we will refer to the specialized centers for prenatal counseling and diagnostic and therapeutic options prenatal. Prenatal counseling and diagnostic and therapeutic options. So, in a systemic review by Sidhu et al., showed that isolated antenatal hydronephrosis resolves in 98% of the cases if anterior posterior diameter is less than 12 mm, versus 51% cases will resolve with larger anterior posterior diameter. And in meta-analysis, Lee et al. Found that the risk of postnatal pathology increases with the degree of dilatation, that is 11.9% for mild, 41% for moderate, and 88.3% for severe HDs. And Sairam et al. Found that 88% of cases with mild ANH resolves in utero or the neonatal period. And Sairam et al. Found that 88% of cases with mild ANH resolves in utero or the neonatal period. Sairam et al. Found that 88% fetal interventions. So if antenatal ultrasound shows evidence of lower urinary tract obstruction, parents should be referred to a specialized counseling regarding prenatal diagnostic and therapeutic interventions and options available. The most predominant cause of lower urinary tract obstruction in male fetus is posterior rectal valves, mostly in the male fetuses. So here we do a fetal vesicostomies and we send the samples for estimation of the urinary electrolytes, osmolality, and beta to macroglobulin. If there are decreasing levels of sodium, calcium, osmolality, and beta to macroglobulin and proteins, it identifies the fetuses are likely to be benefited from the fetal interventions like vesicostomy. So the favorable prognostic factors in the vesicostomy samples are sodium less than 100 milligram per deciliter, calcium less than 8 milligram per deciliter, osmolality less than 200, beta to macroglobulin less than 4, and proteins less than 20. Fetal the options available is either to do a vesicoamniotic shunt to relieve the pressure and or in utero endoscopic ablation of the valves. So mostly these two procedures are performed safely in the second trimester. The meta-analysis showed that prenatal bladder drainage by vesicoamniotic shunt improves perinatal survival in fetuses with severe obstruction, and there is no evidence on improvement of long-term renal outcome or reduces the mortality in fetuses with less severe disease. And so it carries risk of fetal loss, chorioamnitis, and preterm labor. So this is a procedure of vesicoamniotic shunt. This double edge pigtail catheter is inserted. This is the fetal bladder, this is the maternal abdomen, and this is the abdomen, and this is the amniotic space. So the pigtail is inserted, one end in the fetal bladder and one end in the amniotic fluid for drainage. One end from the fetal bladder and one end in the amniotic fluid for drainage. So after delivery, first postnatal evaluation, what are the clues on our examination? So if we find an abdominal mass, it should arise a suspicion of enlarged kidney, either due to obstructive uropathy or a multicystic dysplastic kidney. And any palpable bladder, especially in male baby, especially after voiding, such as the posterior rectal valves. Any single umbilical artery, outer ear abnormalities are associated with increased risk of CACUT. CACUT is nothing but congenital anomalies of kidneys and urinary tract, especially VUR, vesicular ureteric reflex. Deficient abdominal wall with undescended testes with other features or syndromic features such as prune belly syndrome, and any spinal or lower extremity abnormalities should lead to the suspicion of neurogenic bladder. So all the babies should be monitored for renal function test, electrolytes, and creatinine. Timing of USG. When should we do ultrasonography after birth? So the first ultrasound should be avoided in first 2 to 3 days of birth. Why? Because there will be extracellular fluid shift and there will be dehydration in the baby's first 2 to 3 days, and and there will be decreased urine flow through the glomerulus. So there will be underestimation of the hydronephrosis. So when there is an urgency to do the ultrasonography in babies with solitary hydronephrotic kidney or bilateral hydronephrosis with urethral dilatation or any dilatation in the bladder, we should do ultrasonography in first 48 hours of life urgently. In other babies, the ideal time is to do when the baby regains the birth weight. In other babies, the ideal time is what to look for in the ultrasonography. Renal pelvic anterior posterior diameter. This is the renal anterior posterior diameter we'll see in the ultrasound. And other findings are calcium dilatation, whether it is central calcium dilatation or peripheral calcium dilatation. So initially, it will be central, and in the later stages, the peripheral calcium system will also get dilated. And renal parenchymal affection like thinning and other renal parenchymal abnormalities such as poor corticomedullary differentiation, increased renal echogenicity, renal cyst, and perinephric urinoma. And any ureteric dilatation and bladder abnormalities, bladder wall thickness, and any keyhole sign. This is known as keyhole sign. This is a classical ultrasonographic feature of posterior urethral valves. In this, the bladder will be enlarged and posterior urethra is also enlarged, giving an appearance of keyhole. The bladder will be enlarged and posterior urethra is also enlarged. So other features which are important in the antenatal scans are oligohydramnias, which leads to poor development of the lungs, leading to respiratory distress, respiratory compromise in the babies, and major extrarenal anomalies such as cardiovascular system, neurological, gastrointestinal, and any other skeletal malformations for syndromic babies or chromosomal anomalies, and extrarenal soft signs such as increased local translucency, absent nasal bones, echogenic bowel, echogenic focus in the heart, shortened long bones, choroid plexus cyst, and ventriculometally. So classification. Postnatal classification is given by Society for Urology grades is known as SFU grading. So it will be SFU 1, 2, 3, and 4. In SFU grade 1, there won't be any dilatation and urine will be barely visible in the split pelvis. In SFU grade 2, there will be moderate renal pelvis splitting and will be conformed to the renal border and there will be associated with dilated major calcium system. Whereas in case of SFU grade 3, in grade 3, there will be minor calcium system will also be dilated, but the parenchyma will be spayed here. Whereas in SFU grade 4, the parenchyma is also will be thin here. So grade 1, there only barely split pelvis will be there. In grade 2, the intrarenal pelvis will be enlarged with major calces. Here, extrarenal pelvis enlarged with major and minor calcium system dilatation, but parenchyma is spayed here. In this grade 4, parenchyma is also affected. Another classification system, that is UTD, known as urinary tract dilatation classification. In this, type 1 and type 2 will be there. In type 1, central or no calcium dilatation. Type 2, any one of the following features are necessary, like peripheral calcium dilatation system, dilatation, abnormal parenchymal thickness, ureters abnormal, or any bladder abnormality or unexplained hydronias. So now we'll come to postnatal management. So postnatally after birth, we'll do first ultrasonography in 3 to 7 days of life. In less than 48 hours, if any suspected LUTO, that is lower urinary tract abnormalities, lower urinary tract obstruction. What is lower urinary tract obstruction? We have earlier discussed. It will have bilateral hydronephrosis with thickened bladder, dilated bladder with dilated ureter and associated oligohydramnias. So after first scan, if renal pelvis anterior posterior diameter is less than 7 mm or SFU grade 0, there is no abnormality and it is not in hydronephrosis, and we should repeat a scan at 4 to 6 weeks of age because there can be recurrence or hydronephrosis in 1 to 5% of the cases. That's why we'll do a scan at 4 to 6 weeks of age when the baby hydration will be adequate. And then if mild hydronephrosis, that is SFU grade 1 to 2 and renal pelvis anterior posterior diameter 7 to 10 mm, then we should monitor the baby every 3 to 6 monthly until resolution, and we should look for any signs of obstruction or any signs of urinary tract infection. And moderate to severe hydronephrosis or mild hydronephrosis with ureteric dilatation, SFU grade 3 to 4 or renal pelvic anterior posterior diameter more than 10 mm, we should do a micturating cystoectogram. So what is MCUG? What are the indications? Unilateral or bilateral hydronephrosis with renal pelvis anterior posterior diameter more than 10 mm, or SFU grade 3 to 4, or mild hydronephrosis with ureteric dilatation, we will do MCUG. Any suspected lower urinary tract obstruction, we will do it within 24 to 72 hours of life. And antenatal hydronephrosis with urinary tract infection. So in MCUG, we'll insert a dye. First, we'll insert a Foley's catheter to the urethra, and we'll insert the dye, and we'll take the serial fillets. So after doing MCUG, if there is no vesico-ureteric reflex, then we should go for diuretic renography. And if the diuretic renography confirms there is no obstruction, we should follow 3 to 6 monthly until resolution. If the vesico-ureteric reflex is present, then we should start antibiotic prophylaxis. If there is lower urinary tract obstruction, we should refer to the pediatric surgeon for intervention. So what is persistent hydronephrosis without any obstruction? In some way, it accounts for 10 to 15% of the cases. 50% they resolve by 12 months of age, and they need long-term follow-up, that is every 3 to 6 monthly ultrasound until 5 years of age, until resolution. In these cases, if any signs of urinary tract infection, we should immediately do MCUG to look for any reflex, and we should start antibiotic prophylaxis. If there are any signs of obstruction, we should intervene surgically with after doing diuretic removal. So uroprophylaxis, why we'll keep the babies who have been diagnosed as who have hydronephrosis on antibiotics. So higher rates of urinary tract infection have reported in infants with prenatally diagnosed hydronephrosis. The risk of UTI increases if vesico-ureteric reflex is present, and risk is greater in girls compared to the boys. So, in low-grade hydronephrosis, that is SFU grades 1 to 2, the rates of UTI is similar if received uroprophylaxis or not. That is 2.2% versus 2.8%. So, mostly we won't treat any low-grade HDNs with uroprophylaxis. But in high-grade hydronephrosis, that is SFU grades 3 to 4, there are lower rates of UTI in uroprophylaxis group compared to the non-uroprophylaxis group. That is 15% versus 29%. It's a huge number. That's why we'll start the babies on uroprophylaxis in high-grade hydronephrosis. So, in whom will start the uroprophylaxis? That is postnatally confirmed moderate to severe hydronephrosis. That is SFB grade 3 to 4, or renal pelvic anterior posterior diameter more than 10 mm. If any signs of dilated ureter, and babies with vesico-ureteric reflex. What are the choice of antibiotics? If age less than 3 months and more than 3 months, in age less than 3 months, we'll start with amoxicillin 10 to 15 mg per kg once a day, or cephalexin 10 to 10 mg per kg once a day. And more than 3 months, we'll start with cotrimoxazole 1 to 2 mg per kg of trimethoprim once a day, and nitrofurantoin 1 mg per kg once a day. So why we won't use cotrimoxazole in newborn babies less than 3 months is it will this is a sulfa drug, and it will cause neonatal hyperbilirubinemia. That's why we won't use cotrimoxazole in newborn period. And why we won't use nitrofurantoin is it has a risk of hemolysis. That's why we won't use in newborn period. And why won't you predictors of poor prognosis are oligohydramnias, bilateral lesions, renal cortical cyst, elevated levels of urinary electrolytes on vesicosynthesis, reduced lung volume, and presence of multiple fetal anomalies or chromosomal anomalies. Here I want to tell about CAPUT. It's nothing but congenital anomalies of kidneys and urinary tract. These are classified as 4 groups depending on the kidney number, kidney size, kidney position, and outflow tract abnormalities. So, kidney number, that is renal agenesis, complete or partial. Kidney size, renal hypoplasia, renal dysplasia, multicystic dysplastic kidney. Kidney position, horseshoe-shaped kidney, ectopic or pelvic kidney. Outflow abnormalities, uretropelvic junction obstruction, vesico-ureteric reflex, duplex collecting system, megaureter, and posterior virus. So, small notes about the posterior urethral valves. Incident will be 1 in 5,000 to 8,000 live births. There will be a congenital membrane that obstructs the posterior urethra. Occurs when the mesonephric duct fail to regress, adequately regress, and MCU is the diagnostic and therapeutic option is endoscopic valve resection. Multicystic dysplastic kidney, it is a developmental kidney disease resulting in a lobulated kidney with abnormal parenchymal tissue and non-communicating cyst. It's most common cause of abdominal mass in units. Accounts for about 1 per 1,000 to 4,000 live births, and 30% will be associated with contralateral urinary tract abnormalities. There is a conservative management. Prune belly syndrome, it is occurs due to the poor development of the abdominal vessels, so causing the skin of the belly area to wrinkle like a prune, and it will be associated with undescended testes and urinary tract abnormalities like vesiculating reflex and various degrees of hydronephrosis, pulmonary hyperplasia, and chronic renal failure. Another important entity is congenital solitary kidney, CSK. What is congenital solitary kidney? It is an anatomical or functional absence of one kidney from the birth. So it is classified as 4 types: agenesis, aplasia, multicystic dysplastic kidney, and undefined CSK. So agenesis is absence of one kidney suspected on ultrasound scan done between 18th to 22nd weeks of gestation and confirmed postnatally. Suspected on ultrasound scan done between 18th to 22nd weeks of gestation and confirmed postnatally. Aplasia is a rudimentary kidney suspected on ultrasound scan between 18th to 22nd weeks of gestation with relative function less than 5% on DMSA scan. What is multicystic dysplastic kidney? Multiple non-communicating cysts of various sizes are present within a lobulated renal counter known as bunch of grape appearance, not being visible on the ultrasound. So another entity is undefined, means detection of an empty kidney fossa in the 3rd trimester of the pregnancy or after birth with the differential diagnosis of agenesis, aplasia, or an involuted multicystic dysplastic kidney. So for congenital solitary kidney, classified as either agenesis, aplasia, multicystic dysplastic kidney, and undefined type. So what to do in congenital solitary kidney? So we have on routine antenatal screening, we have found that there is only one kidney in it. So what we should do antenatal means in regards to antenatal counseling. So in case of congenital solitary kidney, as an isolated malformation, there no diagnostic procedure other than standard obstetric ultrasound is necessary. So if there are no isolated anomalies, only scan is sufficient and there is no role for any other diagnostic interventions. But in fetuses with diagnosis of congenital solitary kidney associated with extrarenal malformations, then we should go for chorionic villus sampling or amniocentesis with chromosomal microarray, or karyotyping should be offered to look for any syndromes or chromosomal abnormalities. For the definitive diagnosis of congenital solitary kidney, a neonatal ultrasound performed an experienced pediatrics radiologist is sufficient in most of the cases after birth. There is no need of routine use of scintigraphy to confirm the anatomical or functional absence of kidney in case of isolated CSK. But if any other features are there, then further imaging is recommended. But if any other features are there, then further imaging is recommended. And in congenital solitary kidney, without any additional abnormalities, isolated forms, we expect the other kidney, which is not, the kidney which is there, to undergo the compensatory growth. So, measuring the length of the congenital solitary kidney at diagnosis and at each follow-up should be done. 3 to 6 monthly follow-up should be done. The length of the congenital solitary kidney should be evaluated with nomograms, and there are charts pertaining the length of the kidneys, and we should measure the baby height, and we should plot the kidney length. So renal parenchymal measurement are also necessary if there is any abnormal morphology. With normal morphology, only the kidney length is sufficient. But in case of abnormal morphology of the kidney, the renal parenchymal measurement is also necessary. And compensatory hypertrophy is expected till 2 years of age. And we'll perform only urine analysis to rule out the proteinuria in cases of congenital solitary kidney. Only that investigation is sufficient. But if any other abnormalities are there on ultrasonography, the renal parenchymal involvement or any sudden increase in the size of the kidneys, then we should order plasma creatinine and quantitative proteinuria. When to refer to surgeon in case of antenatal hydronephrosis. If there is any features of lower urinary tract obstructions, obstructed hydronephrosis with reduced differential renal functioning, that is less than 35 to 40%, or any worsening on the serial ultrasound scans, and solitary kidney hydronephrosis with worsening dilatation. Thank you. Thank you, Dr. Goutami, for giving the first part of this important talk. So some important carry-home messages for all of us are the following. One is, whenever we are sent an antenatal report of ultrasound diagnosed renal pelvic dilatation in the baby, there are some important signs that we look for in the same scan. So whenever we look at the antenatal scans, always make sure that we ask the fetal medicine expert for the renal pelvic diameter exactly, because this will help us to grade the severity. Also look for other features, other important features like renal parenchymal thinning, the presence or absence of associated ureteral dilatation, other renal parenchymal abnormalities such as perinephric urinoma, and the presence of bladder abnormalities like bladder wall thickening or keyhole sign, which can be important markers of posterior ureteral valve. Very, very important other evidence is to see whether this renal pelvic dilatation is also associated with oligohydramnios. So wherever there is oligohydramnios or severe renal pelvic dilatation, then this calls for immediate evaluation. Lastly, also make sure that the fetal medicine expert has commented on other extrarenal abnormalities like associated cardiovascular or neurological malformations, where there is a high risk for associated chromosomal abnormalities, and this is something that we all need to evaluate for. And when we are evaluating these babies postnatally, ask for SFU grading in the ultrasound. So one should not settle for just the presence or absence of hydronephrosis. Make sure that we ask the radiologist for a proper SFU grading. So if you're told that this is the AP diameter, or if there is associated ureteral dilatation, or if there is parenchymal thinning, then you know that automatically the baby has more severe signs. The other very important point for all of us as pediatricians to know is when we need to do an urgent MCUG. So an urgent micturating cystourethrogram is indicated if any baby postnatally has ultrasound evidence of LUTO, that is lower urinary tract obstruction. This could be in the form of bladder wall thickening, diverticulae, or presence of keyhole sign. If any of these signs are there, you need to go for urgent MCUG. Dr. Goutami has also told you the other indications for going for MCUG at a delayed stage. Now, to take this forward, we have our Chief Pediatric Surgeon and Pediatric Urologist, Dr. Nagendhar, who will be talking to us about the surgical aspects of a baby with antenatally diagnosed hydronephrosis. We have already discussed when to refer to the surgeon, where we have features of lower urinary tract obstruction, obstructed hydronephrosis with reduced differential renal function, or in a baby with solitary kidney with worsening dilatation. So here comes a very important role of the surgeon, the urologist, in managing these cases. So with this introduction, I'll welcome Dr. Nagendhar, sir.
I welcome you all to this important session, which is about the pediatric urology, most important part of pediatric urology, which is fetal hydronephrosis. Commonly nowadays we encounter fetal hydronephrosis. I am Dr. Nagendhar, Chief Pediatric Surgeon from KIMS Cuddles Hospital, Hyderabad. So this topic is very important because, as I told, the first ultrasound report that antenatal scans, prenatal scans actually often they give is dilated pelvic tests or mild pelvic tests, moderate, severe pelvic tests. This confuses the parents and, of course, even the doctor who is taking care of the baby. So often, actually, obstetricians will be referring us to the pediatrician or pediatric surgeon or pediatric urologist. So after that, we'll be taking care and then we'll be deciding what we have to do with that patient. So after that, we'll be taking this. So with this brief background, actually, I want to talk about actually the concerns that the parents have and the concerns that obstetricians will have and how they are going to ask how the family is going to approach the pediatrician, neonatologist, and the pediatric surgeon. And in the antenatal counseling, what we are all supposed to do. So all these things actually we'll be discussing in the coming slides. And in the antenatal counseling, what we are all supposed to do. So all these things actually we'll be discussing in the slides. So whenever a hydronephrosis case comes, actually the first thing that all of us are concerned about is actually what are the types of hydronephrosis which are involved. So some are surgical causes, some are non-surgical causes, and for that actually first we should be able to evaluate actually which is the surgical cause, which is not the non-surgical cause. And for that actually first we should be able to evaluate actually which is the surgical cause, which is not the non-surgical. And for that so I shortlisted few of the conditions, and then we'll be discussing mainly about these topics. But there are several conditions actually which we'll be able to diagnose only after the baby comes out. So before that, actually, we'll just see scroll down actually what are all the conditions which can be leading to the antenatal hydronephrosis, and which are of concerns in the priority list. So the most common, actually, all of us know is pelvic ureteric junction obstruction, which comprises around 10 to 30% of the cases. And sometimes the obstruction can be at the range of actually till the lower part of the ureter, where it is joining the bladder. That is what is called the uretrovesical junction obstruction. And sometimes there can be ectopic ureters. Like ureter itself is actually at a lower level, which is often seen in case along with duplex moiety, which is seen around 3 to 4% of the cases. And sometimes actually they'll have isolated ureterocele also. So where the lowermost part of the ureteric orifice into the bladder is distended, because at the orifice is so narrow and the wall is so thinned out, and it will lead to a bulgy swelling, actually, which will lead to what is called as a ureterocele, which will lead to hydronephrosis. And sometimes, and most common, frequently what we saw is the vesico-ureteric reflux, which we commonly see in pediatric age group. That all these things actually we'll discuss in detail. So I jotted down as posterior urethral valves, actually, which comprise around 1 to 2% of the diagnosis, but it is a significant diagnosis because it changes the prognosis of the family itself completely. So prenatally, whenever diagnosis is done, actually, and when they are watching these unborn babies, so most important thing actually all of us should know is it a correctable problem or is it not a correctable problem? So if it is a correctable problem, we have to give them a chance to live. So So always, as in the modern era, we should not allow the babies to be terminated by enhancing the knowledge of the treating doctors. So let us say no to terminations for treatable causes. So whenever antenatal diagnosis is made, uh, if it is a surgical problem, let us give a chance. And so many thoughts will be there in parents' minds. With those thoughts, actually, will be coming to us. Let us talk to them with compassion, care, and tell them that there is no need for you to give away the baby. There is a hope for the baby. It is us who should give us the good and the hope. So birth defects as such are nightmares for the mother and the family. So we have to do a proper antenatal counseling. And thanks to our fetal medicine, actually, they are able to diagnose even the minute details nowadays. And they are able to help us with so much of knowledge before only. If at all, if we want some more, actually, definitely they are there to help us. So parents need to know many things about embryology and what is the problem and what are the treatment algorithms and what are the possible outcomes. So today we are going to discuss mainly about the possible outcomes. So once a fetal diagnosis is made, from termination to where to deliver and what to do after the delivery, all these things actually we are going to discuss. So ultrasound is significantly changed our lives as prenatal counseling doctors. So most of them are diagnosed nowadays, and with the real-time ultrasound, actually they are able to make out what is the present condition, what is the condition after 1 week, after 2 weeks, after 3 weeks, and they're allowing us to give a family a chance to terminate if at all, if it is necessary and indicated, and it is ethical and it is medically accepted. MRI in pediatric urology has got very few in instances. But as of most likely, actually, we'll try to avoid MRI unnecessarily if it is not necessary because ultrasound is equally good or more than MRI. So overall, it is a teamwork by neonatologists, pediatric surgeon, and supporting staff. So most as pediatricians, actually, all of you know actually which is a salvageable kidney, which is not a salvageable kidney by doing a simple fetal urinary sampling, actually we'll be able to make out if the sodium is less than 100, chloride is less than 90, and total proteins are less than 40, beta-2 microglobulins are less than 4, and osmolarity is less than 210. So these are only indicators. That doesn't mean that actually, yes, actually those things are more actually going to terminate the baby. Still, we have to see a baby as a whole. There are very few medical indications actually for us to terminate. Something like actually bilateral renal agents is, yes, it is not viable at all. So God itself is not going to take away the baby. So these are the conditions actually where medical indication for termination of pregnancy is accepted. Suppose even a bilateral infantile polycystic kidney, actually that is also a bad condition. And few cases of, most of the cases of the megacystitis, cystis are also actually indication for surgery. And if at all a termination, if at all if they are associated actually various other add-on reasons, so that will become actually add-on reason for termination of the pregnancy. But after everything, it is a parent's wish whether they have to continue the pregnancy or not. So sometimes the baby will be very precious if they want to take the risk with the baby. So then, as a hands tied doctors, we cannot do anything now. So coming to the transport of the newborn, yes, actually all of us know mother's womb is the best. So now the question comes, when to operate? Is this operation immediate or is it operation actually we can do it at a later time after proper evaluation and when the time comes? All these things actually will be discussed in our actually, pediatric urology clinic with us when the parents come to us. So vomit is a condition, is a word actually which is used, means victims of this modern imaging technology. It's a funny terminology, but actually it is very important. So some radiologists actually they are diagnosing actually antenatal hydronephrosis. But what bottom line is actually every pelvic tesis is not important. Every pelvic tesis is not going to become progressive. Every pelvic tesis will not lead to a surgery. So there are many hydronephrosis or pelvic tesis which will just arrest, which are non-progressive. They will just follow them up throughout their life. But that follow-up is very important, and we play a very big role in that follow-up. And so coming to the significance of this pelvic tests, usually what we talk radiologists tell us is something like 4 or 5 in the first trimester, later 8, and at term. So usually what as pediatric surgeons and pediatric urologists, what we call it as at TIFA, if it is 8 mm, more than 8 mm, and if at birth, if it is more than 10 or 12, they're definitely significant. Those are the conditions actually where which needs a proper follow-up. Sometimes they resolve actually over as the antenatal age progresses. Significantly around 80% resolution rate is noticed. So again, coming to the termination of the pregnancy, when to terminate, actually we discussed, and those conditions where actually it is not viable, those are the conditions only which are which mandate termination of pregnancy, not every case, because our rule in this era is to allow every baby to survive. And because we have actually very advanced techniques and advanced anesthesia techniques and excellent endoscopic equipment, so we are able to achieve almost near normal life to the baby after it is born. So coming to the literature, what it literature says is actually a pelvic test is something like more than 35 has usually a bad prognosis, because these are the people actually who may go into renal dysplasia at a later age. But often less than 30% actually 30 AP diameter pelvis, they are doing fairly decent enough from what the literature says. In neonatal urology, today we are going to discuss about few topics like hydronephrosis, solar hydronephrosis, but obstructive hydronephrosis, multicystic dysplastic kidney, renal agencies, bladder extrophy, and sometimes hypospadias if it is very tight, and that also can lead to hydronephrosis, which is often ignored, but it is a possibility, and some intersex conditions as well. First, let us deal with the obstructive uropathy. So, obstructive uropathy, as we discussed, actually the most common cause is PUJ obstruction. So, how to come to a diagnosis that it is a PUJ obstruction? When the baby is in antenatal womb itself, then we'll know that yes, pelvic test is there, mild, moderate, severe. These are all fancy numbers, but they are very important. And postnatally, after the baby comes out, so what actually by now you know actually by for 3 to 4 days, usually there will be oliguria. That's why even if the significant hydronephrosis is there, it can be detected by the radiologist as a mild or no hydronephrosis. That's why actually sometimes it will be getting ultrasound in the first day itself. It will be negative. Later in the next 1 month scan, actually they'll suddenly find out that doctor it is again positive. So how this can happen? It is because the first few days actually baby is not settling well. It has come into the environment where it is losing water and all. So, and overall, the baby is oliguric. So, these are the kind of places actually where you have to withhold your apprehension and control the parents' apprehensions and tell them we will do the scan only after the 72 hours or first 4 or 5 days of life. That scan will be the reference scan, and which we'll be comparing. Always we'll be comparing with the antenatal scan and this scan, and every month we'll be repeating the scan. So ultrasound, what are we expecting in the ultrasound is AP diameter of the pelvis. So whether the AP diameter of pelvis is more or less, this is going to determine how fast we are going to intervene with the baby, how fast we are going to take care of this baby or evaluate this baby, or shall we give more reassurance to the family? Because sometimes actually too much reassurance to the families actually it can be detrimental. Then they may silently tell actually it's you doctor who told us not to hurry up, or else we would have as well done. So it is our primary responsibility to judge which condition requires early intervention, which conditions require later evaluation and intervention. And not every hydronephrosis I was talking about actually are progressive. Not, and some are just simply non-progressive. Non-progressive just require a follow-up scans, and then we'll be seeing if the baby is going to have urinary tract infections or some other issues. But otherwise, actually, they just need a follow-up. But sometimes in progressive also, there are two types of progressive hydronephrosis. One is rapidly progressing, one is slowly progressing. So I have seen many conditions actually where the antenatal scans have gone up to 40, 50, with every month actually it will be going by 10 mm. So those are the conditions actually where it is going very significantly and rapidly higher. So coming to the other conditions actually which we see in obstructive hydronephrosis, it is not a per se obstruction within the lumen, within the tube itself, but it is extrinsic compression by a crossing renal vessel. Sometimes actually the aberrant vessel will be there, which should be crossing the renal vessel. This is what actually we used to talk about a Diethel's crisis. Diethel's crisis actually suddenly it will be pelvis will be increasing as the gravity supports the pelvis will start draining the urine. So hydronephrosis will be seen in some episodes and some scans actually it won't be seen. So these are the conditions which need special attention, and those conditions require a CT scan or CT angiography to confirm whether crossing renal vessel is the reason for the pelvic ectasis. And most important, the bottom line for all these hydronephrosis cases is a delays, be it a delay from our side, from our counseling side, or from the parent side. So any significant delay in a rapidly progressing hydronephrosis can definitely lead to a non-functional kidney, which finally will lead to the nephron loss and renal loss, and maybe we'll be forced to do a nephrectomy. But with the advent of all the evaluations and management policies, we are able to almost decrease nephrectomy rates for pelvic ectasis cases significantly. So all of us know actually in congenital hydronephrosis, it is the obstruction which is there at the pelvic ureteric junction. So the tighter the obstruction and the longer this is narrowing, the significantly progressive hydronephrosis is the sequelae. So, so we'll be following it up actually at 8 mm, it's actually at 8 mm, 12 mm at birth, and then after ultrasound after 72 hours, and then first month again we'll get one more ultrasound. So in this meanwhile, actually, parents will ask, what should I do? So as all of us know, and all of us do, we are going to give the babies actually a prophylaxis of uroprophylaxis to prevent urinary tract infections. Any obstructive system or any refluxing system, any system where urine is stagnant is a potential cause for urinary tract infection. So to fill that blank with antibiotic solution, we are able to successfully actually reduce the urinary tract infections. So uroprophylaxis, you usually one-third dose or half the dose actually according to the protocols which we follow. So we'll be giving some urinary specific antibiotics, and then actually we'll be following it up till the problem is settled. And then at the age of around 3 weeks, actually earlier we used to do DTPA scan, and nowadays in advanced cities and all, actually we are able to get what is called as an EC scan, which is a radionuclide study, actually which will tell whether this kidney is an obstructive, showing obstructive pattern or not. So in obstructive pattern, actually how it is going to be, actually I'll show you in the coming slide. As all of us know, actually there can be around 5% chances that actually a patient can have vesicular reflux along with the PUG obstruction. So knowing that actually if a vesicular junction view reflux is there or not is our basic requirement. So MCOG, many people actually advise MCOG for a case of PUG obstruction, actually congenital hydronephrosis cases, because all these associations actually we cannot predict whether they are there or not. So, and coming to the treatment, actually, all of us know actually it is a modified Anderson-Heinz pyeloplasty, whether we do it open or laparoscopic, but often the trend is more towards laparoscopic pyeloplasty, which we are doing regularly. Coming to the radionuclide study, actually, which I am talking about, actually, be it DTPA or EC scan, according to the availability of in the radionuclide nuclear scan center. So we'll be doing a radionuclide study. So usually it is the right one is the right and left one is the left. DTPA scan. So as you can see in this picture, actually the left kidney it is filling and it is emptying, and then it is completely empty. On the right side, there is slow filling because actually the filling phase itself is slow because there is outlet obstruction. That's why because of the pressure, the filling phase is slow. So slow filling and it is filling, and at the end of the phase also, after the voiding phase also, the bad kidney is still full. That is because there is a significant obstruction. Seeing this picture, actually all of us can make out that there is an obstruction. And coming to the graph, actually, which we gave, they gave, the graph shows left kidney, the kidney is rising up, and then slowly it is emptying, and after the Lasix is given, and there is emptying, and slowly it is emptying. So that's why you will see a downgoing curve. But in a obstructive system, what we see is actually, even after the Lasix is given, there will be a significant increase in the and slowly up curve, up sloping of the curve will be there. So this is the basic requirement actually from what is required from this. So if these things are there, and we can clearly make out that it is a case of a obstructive hydronephrosis. So if we are seeing actually ureter also, if we are seeing ureter also along with the kidney, then you understand that actually maybe it is a case of a vesico-ureteric junction obstruction. Means the ureter also is blocked. So by seeing the picture itself, actually we'll be making out actually whether there is a vesico-ureteric junction obstruction or pelvic junction obstruction, or sometimes actually we'll just see sometimes in some pictures we'll be seeing a ureter. That means it might be a reflex in ureter. So this is the basic knowledge that is enough for us. Actually, yeah, we'll go with that. So coming to the hydronephrosis, actually, after the antenatal diagnosis is done, there is a possibility of recurrent urinary tract infection, which we are controlling with the uroprophylaxis or antibiotic, which we give usually at the night time, because nighttime stresses is more. Maybe in newborns it may not make out, it may be logical, but it is usually in the night time we give. So early evaluation, early intervention protects the kidneys. This is the bottom line for all the problems and kidneys altogether. Because God gave us only two kidneys, those two kidneys should be taken care of very well. And I was insisting that a laparoscopic pyeloplasty is a gold standard nowadays, because we are giving the least and the best scars possible for these newborns and the family for the lifetime. So what we do is actually we'll excise this pelvic junction, and then we'll remove this piece, and then we'll place one stent across, and which the stent will be removed after 3 to 6 weeks. So this is how actually we'll be identifying actually the pelvic junction, and then actually we'll be excising this segment, and then we'll be anastomosing actually by putting intracorporeal knots, means putting the knots inside, and stent also will be placed, and it will be confirmed. So again, actually coming back to the same thing, actually the early diagnosis and treatment saves the kidneys. And coming to the megaureters, what is a megaureter? When do we call a ureter a megaureter? Luckily in pediatric surgery, most of the things actually whichever are dilated, some small, or often the tubes are less than 6 mm. If the tubes are more than 6 mm and 7 mm, that is the condition where we call it as a megaureter. So anything more than 6 mm or 7 mm, actually we call it as a megaureter. So if at all, if associated actually the kidney along with that actually ureter is also dilated. So those are the conditions actually which needs a special attention and special evaluation. So unilateral hydronephrosis can be, as we said, discussed, actually it can be because of the obstruction, it can be because of the reflux as well. So how we are going to diagnose postnatally after the baby comes out, actually along with ultrasound, we find out that ureters are dilated, and then after that actually we'll be doing a VCUG or MCUG, whatever we call it, and accordingly, if the VCUG shows there is a reflux, we'll be doing a DMSA scan. If the VCUG is not showing a reflux, then we do what is called as a DMSA or EC scan, and then we'll find out if there is an obstruction. So accordingly, actually, it means we have to use our logic in each and every step. That is what we are meant to be. And there is a rare condition called actually non-reflexive, non-obstructive megaureters, that's dilated ureters. They need a special attention. We will discuss about it a bit later. So we were discussing that actually it can be because of the reflux or it can be because of the obstruction. So if at all, if it is because of the obstruction, so because it is obstructed and these are newborns, we have to take care of the kidneys. If we leave till 1 year of age, usually that is when we do the ureteric reimplantation surgeries or some procedures. If we leave it till that age, obstructed megarotic actually can go into toss, and then actually these are the people actually where the kidney loss or nephron loss will be there. So they may end up in nephrectomy. So that's why, and in the case of obstructive megarotis, actually what we do is actually we do ureterostomy, where the lower end of the ureter, various types of techniques are there. Actually, we'll be bringing out the ureter to the outside, and then we'll be doing ureterostomy, and then we'll be protecting the uh, kidneys for some time, and later we'll be doing the corrective surgery. And sometimes actually what we notice is a solitary kidney, only one kidney is there. If one kidney is there, we have to reassure the family that yes, baby can live with a one kidney as well. So don't panic. This is the most important bottom line, actually, including the gynecologist. There are some people actually who may think that actually one kidney is not viable with life. So as I always tell actually transplant after transplant, a mother donates to the baby, so both of them are surviving comfortably, so you can live comfortably lifelong. So renal agencies is one condition where actually one kidney is not there. Sometimes it can be bilateral; those are not viable with the life. And how we are going to diagnose actually renal agencies is after the baby comes out, absence of kidney in the ultrasound, and then actually we'll be doing a TTP or EC scan, and then we'll be confirming that it is a renal agencies. Nothing much to be done, but only thing is other kidney is the only viable kidney, and that should be protected. And usually that will go into compensatory hypertrophy, which will take care of the overall function of which both the kidneys are supposed to do. So they're very much viable and almost a normal variant. So coming to the most common thing actually that all of us are worried about is post-urethral valve. So post-urethral valve, before talking about post-urethral valve, actually we need to know a little bit about what is megacystis. Megacystis is actually where the bladder is very much dilated. As you can see in this antenatal picture, the bladder is very much dilated. Literally, it looks as if the baby is holding the baby bladder back. So that if at all, if keyhole sign is there and others, if it is a male child, only then actually we'll be able to make out actually maybe it is a case of post-urethral valve. And along with that, actually, if the ureters are dilated or not, and how bad are the kidneys, and how bad is the bladder wall thickness. So all these things will decide actually whether it is a case of a post-urethral valve. So by one doing actually postnatal one MCUG picture, actually we'll be able to make out actually this is the case of the post-urethral valve. So once the diagnosis of post-urethral valve is made, so what we do is actually we'll catheterize the bladder, and we'll see there should be a fall in the creatinine values. So maybe day one actually it might be maternal creatinine values, but day two actually we'll be doing the creatinine values. And after passing the urinary catheter in the urine across the valve, so there we should document the fall in the creatinine, usually by 72 hours. Or if sometimes actually we wait almost for 1 week to fall to allow the urine creatinine levels to fall down. So fall down means actually it should start decreasing. That is when we'll understand that actually by doing a fulguration of the valve, this baby is going to be better. So then we'll plan for what is called as a cystoscopy. So, and in cystoscopy, actually we'll see it is a diagnosis. Along with that, actually it is a therapeutic procedure also, where we'll be cutting the valve, and then the valves will be cut. And this is the first step of the treatment procedure in case of post-urethral valve. And it is not the end of that, actually, because we have to address many things. Actually, here we are addressing only the valve. So above the valve, there is a dilated posturethral. Above the dilated posturethral, there is a thick hypertrophied bladder wall. So that bladder wall needs to have special attention. Along with that, actually, both the kidneys, actually, both the ureters are tossed. So all these things need attention at many phases of life. So post-urethral valve cystoscopic fulguration is just the beginning of the treatment, and it is not the end of the treatment. Sometimes, actually, what we used to in earlier days, actually, is vasocostomy. Sometimes, actually, the baby is so preterm, actually, or the baby's condition is bad. So in those cases, actually, what we do is a vasocostomy, and we'll be opening the bladder by doing what is called the Bloxham type vasocostomy. And then uh, this vasocostomy will be temporary. And when the baby is ready for a proper fulguration of the valves, and when the bladder pressures are reducing, then we'll be proceeding with the further management. So sometimes there will be supravesical issues, means it is nothing to do with the valve itself. Along with that, actually the upper level, next level of block is the vesicular junction blocks, because the bladder wall is hypertrophic and thickened. So there can be blocks at vesicular junction also, bladder to ureter junction. So if that is the case, actually, then maybe we may have to go for a ureterostomy, unilateral, bilateral. Because after everything, actually, you can understand the bottom line is save the kidneys. So nephrons are once in lifetime. Actually, we have to save each and every nephron as much as possible. The more we delay, the less we intervene and follow these patients. These people are going to go into end-stage renal disease, which can lead to very detrimental for the family. So there is one more condition called duplex moiety, and we discussed about actually uretrocele. And duplex uretrocele and duplex usually they go in a combination as a combination. According to Wiegert-Meyer's law, what we call, so two units of kidneys are joining, and when two units of kidneys are joining, the two ureters actually will be coming, and sometimes there will be complete duplication, sometimes there will be incomplete duplication. If it is a complete duplication, the upper kidney ureter will be going to the lower end, and lower kidney ureter will be going to the upper and little bit lateral end of the bladder. So as it is goes into the lateral end, there will be more of reflux. As it goes lower down, there will be more of narrowing, tightening, stenosis, all these conditions. So when it is narrow, actually, especially the lower one is going to have what is called as a uretrocele. Uretrocele is the bulge in the lowermost end of the ureter. So often they are obstructive uretroceles. And in a newborn, actually, what we do is we just puncture that uretrocele by doing cystoscopy, and then we are going to relieve the pressure. But sometimes the puncture can be dangerous because the puncture per se can lead to what is called as a reflux. So, but managing a reflux is much easier than managing an obstruction. So that's why we prefer to have a refluxing ureters than to have a obstructive ureter, because obstructive ureter will definitely literally kill the kidney. So we do initially ureterocele puncture, and then at the age of around 1 year, we'll do what is called as a ureterostomy, where ureter will be attached to the other normal ureter, or what we gotta do it is a common sheath ureter reimplantation. This is what we do in the case of a duplex moiety. All these things are done actually mainly to protect the kidneys as early as possible, and with the timely intervention procedures. So maybe this slide sounds irrelevant in a neonatal topic, but any newborn, be it boy or girl, a documented urinary tract infection needs evaluation. Sometimes actually we always tell circumcision is not enough, and we have to evaluate. So because often actually they'll be because of the refluxing ureters, actually sometimes we see, and or it can be some per se it is because of the phimosis itself, which can lead to by doing circumcision, which can lead to uh, prevention of urinary tract infections. But after complete evaluation, only we have to rule out that. So coming to the most important and interesting topic of the day, which is the vesicular reflex, often we see. So this is the one actually where actually lead to recurrent urinary tract infections. So recurrent documented urinary tract infections actually we needs a proper evaluation by doing a MCUG, MCU micturative cystorectogram or a body cystorectogram. So which will confirm that the child is having a vesicular reflex, and depends on the type of the vesicular reflex actually the child has. Accordingly, actually we will be evaluating and managing. There are 5 grades of vesicular reflex. So grade 1 is when only the lowermost part of the ureter is involved, and grade 2 is when actually full length of the ureter is involved, and grade 3 is when actually even the pelvis is slightly seen and slightly dilated, and grade 4 is there is mild dilatation and mild prominence of the pelvic calcium system, and the grade 5 is where actually where we have actually it is tortuous, grossly tortuous, and all the major calces will be seen in the picturating cystorectogram. So what is the importance of this? So every time the urine is going up, it acts like a water hammer. So like a water hammer, it is going up and it is going to hit the kidney. Every time infected urine hits the kidney, it is going to lead to what we call it as a pyelonephritis. Every time a pyelonephritis comes, it will lead to scar. Any process of infection leads heals by scarring. So we are interested in seeing formation of scars, new scars, and how bad are the scars, which depends actually decides whether we have to intervene and operate early or we can wait. So early grades, all that the child needs is grade 1, grade 2, actually will need a uroprophylaxis, and higher grades actually needs proper evaluation and early treatment. Suppose if the child is less than 1 year of age, that is when actually we tend not to operate actually, even if the child is going into various scars. So that is the kind of place where actually we have what is called as a Dexel injection, which is available nowadays. Actually, what we do is we try to inject at the uh, vesicular junction where it is opening into the bladder, and then there is a process called heat and to heat process actually, where we inject just submucosally, and then we'll try to almost close the ureteric orifice. Means we'll see to that actually there's a little bit of opening, and then we'll try to close as much as possible to prevent the reflux. So by this actually, but unfortunately the success rate with this one is only 60 to 70%, which uh, is no match for a surgery. Surgery actually will lead to almost 100, near 100% success. So, but if we can buy a significant time, and then we'll be able to successfully manage the child without the child going into the scars, kidneys going into the scars, and renal loss. So coming to the operation, actually, there are two types of operations. Again, I told actually one is open operation. The other one, what we do is actually vesicoscopic or ureteric reimplantation, where actually we'll be reimplanting into through a new tunnel and into a new place. Everything will be within the bladder itself. So we put 3 ports and within the bladder, and then we'll be doing this vesicoscopic ureteric reimplantation. That is the trend actually, which leaves literally the baby almost a scarless pelvis. And scars are very important in a vesicular reflux child. So first of all, we should try to prevent the urinary tract infections and the severity of the urinary tract infections, the early management of urinary tract infections. So again, I told about the water hammer effect, which will lead to pyelonephritis, and pyelonephritis leads to scars. And usually they are the polar scars, upper pole, lower pole, and mid polar. And scars, the more number of scars, new scars, all these things are mandate us to go for surgery. So with each and every scar, actually, there is a nephron loss. So it will go into renal insufficiency. And sometimes actually these children can go into hypertension as well. And if neglected, definitely they'll go into end-stage renal disease. And from our surgeon's point of view, a formation of any new scar is an indication that it needs a management. So some surgical intervention, be it a deflux injection or be it surgery. So according to the age of the baby. So we wait for 1 year of age because actually by 1 year, actually the bladder size is adequate enough to do whatever intra-bladder, intravesical procedure that we are attempting. So the bladder can take all those surgical procedures easily and well, or else actually there will be chances of inner damage to the innervation of the bladder. So vesicoscopic uterine implantation is the trend nowadays. So now coming to the one interesting topic, which is multicystic dysplastic kidney. Multicystic dysplastic kidney is where the renal bud and the ureteric bud, they could not meet each other. So because they could not meet each other, actually they behave abnormally, and nephrons have never formed in their lifetime. And finally, they'll be ending up with non-communicating multiple cysts of varying sizes. So there is no renal parenchyma at all. So this is almost very difficult sometimes to differentiate between a badly managed PUJ obstruction hydronephrosis and a multicystic dysplastic kidney. So the evaluation is by follow-up ultrasounds, and then actually EC scan will confirm that actually it is a case of non-functioning entity. So if non-functioning entity is there, it can be a possibility of a multicystic dysplastic kidney because the ultrasound is showing multiple cysts which are not communicating. There's no parenchyma at all. And along with that, sometimes actually there can be associated vesicular reflux, which needs mandates us to do a MCOG, micturating cystoid. So the best part of this multicystic dysplastic kidney is, yes, it is not functional. And because it is not functional, the opposite kidney is going into compensated hypertrophy and taking care of it. And but the best part is it is self-involuting. So because slowly the cysts are not getting any function, So automatically it is not working. It is automatically it will start involuting, and to such an extent to say it may as well disappear at one point of time. So hardly anything will be seen. So something like a 1 centimeter or 2 centimeter kidney will be seen. So which is not going to lead any problems to anyone. But if this kidneys are sometimes they increase in size, if they are large, if they are progressive, and then actually this pressure can fall on the renin-angiotensin system, which can lead to hypertension. And other thing that we all of us should see is actually if urinary tract infections are coming or not. And if at all, actually, if there are some conditions, actually, we may be forced to do a nephrectomy for this non-functional kidney. So then laparoscopy is the best answer and the simplest answer. And there is no role for open nephrectomy for a case of multicystic dysplastic kidney per se. So I said actually vesicular reflexes are seen around 30% of the cases. And this is how actually it will do count table. Actually, literally, there is no renal mass at all. And this is how actually what we used to do. This is what my one of my operative pictures, which I did 20 years back. And this is the picture actually of the same kidney. And all that this child needs is observation, and we need not be in a hurry to do the operation. And we have to explain to all these parents about the single kidney status. So this is what I was talking about, actually, megacystitis. Actually, megacystis is one condition where the bladder is so grossly distended. So when do we call it as a megacystis? Actually, if the bladder in the first trimester within the 10, 11, 12 weeks, if it is more than 10 mm or 12 mm, that is the condition actually where we call it as a megacystis. So usually, often actually around 10% of the cases are being idiopathic or transient. 10% of the cases they resolve by themselves. So every week, actually, megacystis is a condition where actually we do scans every week. We want to see whether it is a post-urethral valve. We want to see it is because of some other reasons, or if it is because of the imperfect hymen or something. So all these conditions actually needs to be evaluated. So so sometimes they'll be obstructive, and around 60% of the cases actually it can be because of the urethral atresia, stenosis, or cloacal anomalies, and it can be because of non-obstructive reasons like prune belly syndrome or megacystis, microcolony, intestinal hypoperistaltic syndrome. So these associations actually are important because actually it will decide whether we have to continue the baby or we can give an option of termination of the pregnancy. So there are various causes actually like I discussed in the previous slide. If this measurement of the bladder is increasing, then we will call this as a progressive fetal megacystis. So those are the conditions actually which requires a special attention and which may need epidural if it is associated with multiple anomalies. Those are the conditions, yes, actually we may suggest the termination of the pregnancy as well, which is ethically and legally accepted. So there are few actually antenatal surgical interventions at this point of time. I thought where we can discuss vesicoamniotic shunt. By putting a vesicoamniotic shunt, we are diverting and we are reducing the bladder pressure. But unfortunately, they have seen many pitfalls because sometimes they'll just come out. Sometimes the vesicoamniotic shunt can go into the intestines or the free peritoneum. So that's why actually we do it very carefully, and there is a significant some amount of maybe around 5% possibility that actually these people there can be pregnancy loss as well. So ablation is another of the valves or is another condition where we do in megacystis, and fetal cystoscopy is one fiber optic actually we're not a rigid one we are doing, and then we are ablating the valves as well, and these are all in the preliminary phase, but it is not done in all the centers. So spontaneous regression is there or not is an important thing that all of us should follow up in the coming scans. Again, just to show actually the same continuation of the megacystis, this is an MCOG picture where you can see a significant dilatation of the posterior urethral valve, posterior urethra above the valve, and then the bladder. Actually, you can see the bladder shape is totally disappeared because of the multiple micro trabeculations. Actually, which will be because of the high bladder pressures, and some there will be associated sometimes actually unilateral reflux. Unilateral reflux are sometimes very good because actually they work out as a pop-off mechanism. So there are other pop-off mechanisms also. Pop-off means the pressure is popped off. So those are actually unilateral reflex is one, and a large congenital bladder diverticulum in the posterior valve is another thing which will take the brunt from the bladder. And sometimes the pressure is so high that the urine starts extravasating from the kidney and the pelvic calcium system. And this is when we call it as a urinoma or urinary ascites. These are the all three conditions actually where we call it as a pop-off mechanisms. Some people tell they're good, but we personally feel actually they're bad because they're talking about a very high pressure bladders. So not that actually pop-off mechanisms are always good mechanism, but it is taking off the pressure from the bladder. So that way it is a better mechanism. So each condition in the posterior valve needs to be addressed separately. So diverticular needs attention, posterior valve needs attention, and bladder needs attention. Bladder needs bladder antispasmodics after the procedure is done, and ureters needs a follow-up, and the kidneys need actually assessment actually whether they are going into renal failure or not. So to such an extent, actually, they will be continuing with the CAC, and sometimes we'll be going for augmentation of these bladders as well. So earlier we used to do actually vasectomy and taking care of the vasectomy. All these things actually will be explained to the mother because it will lead to amniotic excoriation of the abdominal wall. So with the advent of endoscopic procedures, actually we are able to do primary fulguration of the valves. Even in extreme preterm babies, actually we have excellent endoscopic equipment. We are able to achieve actually fulguration of the valves. A little bit of mention about the bladder exstrophy because bladder exstrophy is not simple bladder exstrophy, and it has got a combination of other problems like actually where because the ureters are having abnormal insertion into the so-called bladder, this will lead to bilateral vesicotic reflux, and this hydronephrosis needs a totally different and special attention. So, yeah, bladder exstrophy epispadias complex actually is a special condition where it needs a special class, uh, and we'll discuss in the coming sessions. So just to complete, we have to see other conditions where hydronephrosis are there. Antenatal malformations are the conditions where there can be associated renal malformations. So always an antenatal malformation case, we as pediatric surgeons will be following it up with ultrasounds, and then sometimes we'll be doing a maturing cystorectomy or voice cystorectomy to see if reflux is there, if that is a cause for urinary tract infections. Because we have to see any baby as a wholesome. That's why that is how actually all these associations, syndromes, and Bacterial, all these conditions have come because these syndromes and associations are telling doctors to be a good doctor to see all the associated conditions along with uh, not only the primary condition, see all around. Fetal surgery is still in the new, very primitive phase, and I personally feel actually over 20 years I have thinking of practicing fetal surgery, but there's so many ethical reasons and so many conditions. Which parents are not ready to take the loss, and the equipment is totally different. But yes, it is evolving, and it will be evolving. Maybe before Reddy, actually, definitely fetal surgery is going to be the thing. And it is our responsibility to take care, treat the condition, and then save the kidneys with timely intervention and timely management. So this is how we can stay the end-stage renal disease, and protecting the kidneys is our primary responsibility. And by doing a timely management. And again, the debate continues actually whether I have to terminate this baby or not. I feel actually a fetal medicine specialist, not the mother, not the gynecologist, not the neonatologist, not the pediatric surgeon, has the right to terminate this baby. It is we have every baby needs a chance, and whenever it is a treatable condition, yes, we have to give it a chance. Let the baby survive because we have excellent equipment, and nowadays the laparoscopic, the cystoscopy procedures are there with which in the best neonatal care, and our neonatologists are excellent. And with this, actually, we are able to manage the babies actually very comfortably and successfully in most of the conditions where the treatment is possible. Yes, in some conditions where treatment is not possible, yes, actually, hardly our hands are tied up, we cannot do anything. So in KIMS Cuddles, actually, we have an excellent team of 4 pediatric surgeons and pediatric urologists, and NSU is excellent, and neonatologists give the best care to their babies, and which is the prerequisite. Actually, neonatal care is very important in such survival of a baby. And pediatric and neonatal anesthesia is another zone actually which we try to neglect, but it is very important. And most important in the fetal urology or pediatric urology or neonatal urology is the timely diagnosis, timely management, and long-term follow-up. So all these things need to be addressed and taken care of well, and only then we'll be able to save the nephron and save the kidney and have a renal transplant-free era. Thank you. Already, I have crossed the time. Okay, if any doubts, okay, we can as well discuss, or we can discuss in our YouTube channel, actually, where we'll be continuously giving the answers for any questions actually that you have.